Yes, sorry for the 2 minutes delay. Parimala, you can please start.
Okay, sir. Thank you, sir. So, good evening. I would like to welcome all of you for today's VAA Academics, which is being held on the last Saturday of every month. Today we have guest speaker Dr. Joseph Raajesh. To introduce Raajesh sir, he did his MBBS from Sri Ramachandra Medical College and Research Institute, Chennai, and MD from Government Medical College, Mysore. Presently, Dr. Raajesh sir is a professor in the Department of Anesthesiology and also the in-charge medical superintendent in Indira Gandhi Medical College and Research Institute, Puducherry. Post-MD, he's in academically a strong faculty. He has completed various courses in critical care, palliative care, and emergency medicine. He has been a member of various professional bodies and has organized various conferences, CMEs in and around Chennai. He's a well-known resource person for various workshops, mainly on mechanical ventilation, UST-guided blocks, and echo for anesthetists. He has been a guest speaker in various CMEs, state and national conferences. Sir has around 24 publications in his credit. So with this brief introduction, I welcome you, sir, for today's talk. And it's over to you, sir. Thank you.
Thank you very much for your very gracious introduction. My screen is it okay?
No, it's not visible.
You're not able to get the screen sharing?
No, sir, I have not yet started sharing. Is it?
Yeah.
No, there was some problem in the screen itself. Now, is it okay now?
No, not yet.
Yeah.
Yeah.
Yes, nowhere.
Okay, go for it. Good evening, everyone. At this outset, I would like to thank our Balabhaskar sir and Dr. Srinivasulu sir for giving me this opportunity to share my thoughts and knowledge on this perioperative neuromuscular monitoring topic for the next 30 or 35 minutes. And I consider this as a big privilege shown to me. So to start with, before starting the exact topic, just a small or a short peek into the history. We all know that the 1846 is the landmark time where the first successful anesthetic demonstration was done. However, for the next 100 years, or after nearly 100 years, only that muscle relaxant was introduced. Especially we all know about DTC, the D-tubercular. That's the most famous at that time. But unfortunately, what was following was very high mortality rate associated with this use of DTC. In fact, when this muscle relaxant technique was used, the mortality seems to be somewhere around 6 times higher than the technique just not involving the muscle relaxation. And most, as expected, most of these deaths, around 63% were due to respiratory failure, and the term neostigmine resistant corarization was given to that. But unfortunately, what was not known at that time was people were thinking that this is because of the toxicity of the DTC or the problems associated with the cholinesterase and acetylcholine system. What was not known at that time is that reversal agent, that neostigmine, which was being administered, was administered during the dense blockade of DTC. Because at that time, they did not have any method how to monitor this muscle relaxation or neuromuscular blockade. Way back in 1958, the first introduction of electrical nerve stimulator came into picture, and people started working on it. And a pioneer by name Churchill Davison, who did a lot of work, you must have read it about him in the various articles. In 1965, in his report, he clearly mentioned the only satisfactory method of determining the degree of neuromuscular block is to stimulate a motor nerve with an electric current and observe the contraction of the muscles innervated by that nerve. Even now, the statement holds good. But what is the current status of this perioperative neuromuscular monitoring? Maybe, yes, we do it now and then, but most of the time it is sort of an exception rather than the routine. In 2018, there was a statement, a consensus statement, which was released by in anesthesia analgesia, found definitely certain shortcomings. The first thing, based on the survey, they come to a conclusion that the incidence of routine monitoring is very, very low. The reasons put forth were, the number one, is it because of the lack of awareness of high incidence of residual neuromuscular blockade. The second one is lack of concern for clinical significance of residual paralysis, which is a damaging statement for all of us. And third thing is the over-reliance on clinical assessment. And they went on to say, subsequently, the both subjective evaluation as well as the clinical assessment of neuromuscular blockade should be abandoned ultimately. What about the guidelines? Even though way back in 2015, AAGB released a guideline, ASA has not mentioned anything, American Society of Anesthesiologists, only very, very recently, that's about 2023 January, this month, they have issued their first guidelines, which everyone has to, has to go through that. They have issued few guidelines, which I'll be talking about in my later time. Okay. So the first question come to us is why we need to have neuromuscular monitoring? Why can't we rely on clinical signs? Because we have been doing it for the last few decades. The reasons being, if you are going to monitor the neuromuscular blockade only based on the clinical side, of course, we can't do it intraoperatively. The number two is we cannot predict the spontaneous recovery. The third most important aspect is various studies and evidences have clearly shown that we cannot reliably detect modest degree of residual block. When we are talking about clinical sign, it means that either the 5 seconds sustained headlift or 7 seconds sustained hand grip. Okay. So what are all the advantages when we are not going to have this? We are going to rely on the clinical signs. So what are the advantages of neuromuscular monitoring? To start with, yes, we can have a very good intubation condition. Number two, the intraoperative administered agents, the dose can be guided because we know that the dose can vary from patient to patient. We have come across certain situations where some of the patient comes out very fast, some of the patient do not come out. So to guide the intraoperative administration of this blocking agents, yes, we need to have this neuromuscular monitoring. Then if you want to maintain certain degree of block for that particular surgeries, in some places we want to maintain the block deep, in some surgeries, a moderate block, a surgical block is enough. That neuromuscular monitoring becomes mandatory. Then of course, to time the next dose and predict the spontaneous recovery, and the primary aim and the most important aim is residual paralysis. When I say residual paralysis, what is the residual paralysis? It's TOF ratio, that is TOF ratio is so this article, which was issued in 2005, after nearly about a 10-year period of study, this is what they have done is they have made a structured program where all the OTs were equipped with a qualitative neuromuscular monitoring. And then when the study was done, they were able to show residual paralysis reduction was somewhere from 62% to less than 4%. It's about 3.6%. So definitely neuromuscular monitoring, routine monitoring is going to be very useful in the perioperative as well as the postoperative period. So with this, it's short introduction. My talk is going to be about how the various patterns of stimulation works. What are the different principles of nerve stimulation and different patterns, and how to assess individual one as well as their clinical significance. Okay, to start with, we all would have heard about the all or none phenomenon. So what is this all or none phenomenon? Whenever a nerve fiber which is stimulated, the muscle fiber that is getting supplied, that particular nerve fiber, either it will contract or it may not contract. When it contracts, it will be of its maximum contraction. There is no off contraction or a quarter contraction. It is to be full contraction. So, but we know that each muscle has got a lot of this muscle fibers. So in order to make the entire muscle to contract, we need to have a strength. The stimulus strength should be adequate. So unless that particular stimulus strength is delivered, the muscle will not contract. So what are we going to do? this picture, this graph shows the when you are plotting the muscle contraction or the evoked response against the stimulus trend, we get this S-shaped or the sigma-shaped curve. The first current, what we need to know is ITS, that is initial threshold for stimulation. That is the minimal intensity of the current that is required to evoke a visible response in the muscle. So below which the muscle will not show any contraction. Then as we keep increasing the current, the evoked responses start going up. At one point, the current is sufficient enough to contract or recruit all the muscle fiber so that entire muscle is contracted, and this is called maximal current. But unfortunately, the current sometimes whenever the impedance, the resistance changes, the maximal current that is going to reach the site may vary. So in the clinical situations, what we are going to give is something called supramaximal stimulus. So this supramaximal stimulus is something like 20% higher than the maximal current. This is mainly to make or recruit all the muscle fibers of that particular muscle compartment, muscle group, depending upon because the resistance should not alter the current that is going to reach the site. So supramaximal stimulus is the one which is going to be generated or delivered by our devices. So when coming to the devices, what are the different devices? You must have seen various devices. The picture shows one side we have our usual electric peripheral nerve stimulator. The other side we have modular equipment or monitors that is used for neuromuscular monitoring. So when you say monitoring, what do you mean by monitoring, neuromuscular monitoring? So can the assessment that is done with the peripheral nerve stimulator, can it be called as a monitor? No, because there is something called evaluation versus monitoring or subjective versus objective. Whatever the evaluation, that means it's a subjective assessment where you give the current and assess the response either by visual or tactile means. That means the peripheral nerve stimulator where we don't have any feedback mechanism to display. This is called a subjective assessment, and this cannot be considered as neuromuscular monitoring. Whereas monitoring is objective assessment where the device is going to measure, analyze and display the TOF ratio or whatever the pattern of stimulation we are going to have, that has to be displayed on the screen. So by this definition, neuromuscular monitoring means it should have the display, not our routine peripheral nerve stimulators. Having said that, we'll see certain devices which most of the hospitals we do have only this type of peripheral nerve stimulator, and whatever the type, the concept is the same. The next one is the standalone monitor where the central unit will be there, but additionally there will be a sensor. The sensor will be based on the sensor, the results will be displayed on the screen. This is standalone our neuromuscular monitoring. The third one is the modular monitor, where the module will be attached to the usual our multiparameter monitor, and the screen along with the other monitors, the values will be displayed on the screen. But whatever the type of devices we are going to use for stimulate and for the monitoring purpose, the concept is going to be same. So every unit will have a central unit. This is a central unit, and it will have two electrodes. In peripheral nerve stimulator, we have seen two electrodes, one positive and one negative. In this qualitative monitor, this is called quantitative monitor, this is called qualitative monitor. This quantitative monitors, we have an additional sensor which has to be put against in the thumb, and there will be two electrodes. So there will be this is the sensor which is going to be put against it has to be taped against the thumb. Then there will be a temperature sensor. Some of the module or monitor they don't have this temperature sensor. And this part is a plastic preload. Some of the companies, they do give this. Some of the companies, they don't supply this. And what are the basic concepts of this electrical stimulator? The current which is going to be delivered by this unit should be of a monophasic square wave, not the biphasic. And the most important thing is the width. It should be between 0.2 to 0.3 millisecond, and it should never exceed 0.5 milliseconds. And most of the all the units, they don't have provision to give 0.5, more than 0.5. And maximum current that is going to be delivered by this should not exceed more than 1080 milliamp. So they will be able to, that screen will show you what is the maximum current for that particular unit model or for that particular model. It will be of a constant current and variable voltage. That means depending upon the resistance, the rheostat which is present inside will alter the voltage. But the final current output is what we are going to set. If you are going to set 45, it is going to be of 45 milliamps. And it should be able to produce different types of patterns of stimulation, that acceptable patterns of stimulation, then audible signals with each stimulus, and in case of disconnection, there should be on. These are the basic mandatory features all neuromuscular monitor should have. Okay. So what is the mechanism used behind this is, of course, you would have read in our text, there are various mechanisms starting from electromyography, mechanomyography, acceleromyography, now the kinemyography also has come. But even though the mechanomyography is the gold standard method for measuring or for monitoring the neuromuscular function, because of the cumbersome equipment, it's not used clinically, and it's mostly kept for the research purposes. What we practice or what we use in the OT is the acceleromyography, where it functions on the Newton's, based on the Newton's second law, where the force is equal to mass and acceleration. Mass is the thumb, and which is fixed. So the acceleration, whenever there is an acceleration secondary to the stimulation of the nerve, the force is generated. This force will be transferred to the by use of this piezoelectric wafers. Then voltage will be produced based on the acceleration, and then it will be displayed as the signal. This is what we use at present. So then coming to this, we have known about devices, we know how to stimulate, and the next question is, where are we going to monitor? For this, we need to know the sensitivity of various muscle groups to the muscle relaxant, neuromuscular blockers. So we all know that the most resistant one is the diaphragm, and the adductor abductor comes in the end. Of course, the extraocular muscles comes a little later. So the most resistant part is the diaphragm. But we need to have certain criteria for choosing the muscle that is going to be, or the site that is going to be used for the neuromuscular monitor. So what are the different sites? The most or commonly used one is the adductor pollicis and ulnar nerve complex. The second one is the posterior tibial and flexus hallucis brevis. The third one is the orbicular aculi or a corrugator superciliary with facial nerve complex. So we have three options. Which option we are going to use? So most of the time, the commonest one is used is your ulnar nerve and adductor pollicis muscle. The reason being, it's very superficial. That is the most important aspect, and easy accessibility, because most of the surgical procedures, this arm and hand will be free, and it's a more sensitive muscle, which I've shown you earlier. So if it shows recovery, then there will be no residual paralysis in the diaphragm or the pharyngeal or laryngeal muscle group. And most important point here is the muscle and the nerve are lying opposite side. So the direct stimulation of that adductor pollicis is very rare. So let's see how we are going to how are we going to stimulate this. And we are looking for the adduction of the thumb. So how are we going to place our electrodes? This is going to be stimulated by two electrodes, positive and negative. Always place the negative distally, positive proximally. Make sure that you clean the skin properly, so that whatever the oil or the substances which is going to increase the resistance is removed. So how are we going to place the electrodes? So there are few methods. There is one is direct looking with the mapper. Most of the mapper is not available. So if it is not available, use the your negative one just closer to the flexor crease. Then beyond 3 centimeters beyond that positive electrode has to be fixed. Once it is done, this is the ideal position for keeping the arm. All the other fingers has to be immobilized, because unless the thumb moves freely, the acceleration will not be taken into account. The produced signal will not be appropriate. So that's the reason most of a few of the companies comes with the thumb stabilizer. It also acts as the preload, which I'll be showing during my video subsequently. Okay, then coming to the patterns of stimulation. So either we can give the stimulus only one time, or it can be repetitively done. The example for single stimuli is single stretch, and for repetitive stimuli is we have 4 patterns starting from TOF, which we all know, Titanic and the post-Titanic count, as well as the double burst stimulation. Let's see one by one. First, what is common between these stimulus? whether it is a single stimulus or it is a repetitive, the intensity of the stimulus, what we are going to give does not change. It's a supramaximal stimulus. For the present Indian status, somewhere around 45 to 60 milliamps is considered as a supramaximal stimulus for the ulnar now. Pulse width, it's not going to change. It is fixed by the equipment. It's about 0.2 milliseconds. Then what differs is the frequency. Each pattern of stimulation will have different frequencies, which we'll be seeing much later. The number of stimulus, are we going to give 1 or 4 or 20? Then what is the pause between each stimulus, whether it's a 750 milliseconds or 0.5 milliseconds? So these are the few differences between these multiple patterns of stimulation. We'll start with a single twitch. This is a very basic stimulus, pattern stimulus. And as the name implies, we are going to give only one single twitch with a frequency of either 1 hertz or with the 0.1 hertz. And there is no pause, obviously, because we are giving only one twitch. But what we are anticipating, what we are expecting in this is, in an unparalyzed muscle, there is no depression of the twitch. Whereas if the muscles are paralyzed with the blockers, the height of the twitch is going to be depressed, which is called as twitch depression. But both neuromuscular groups, that is your depolarizers and non-depolarizers, behave in the same way in this, as long as the single twitch is given. But only thing is the time difference will be there, but both will produce a sort of a twitch depression. So we cannot differentiate based on the single twitch, whether it's a depolarizing block or the non-depolarizing block. So usually it is used for picking up the supramaximal stimulus at the beginning of this. So first the twitches were well visible, but now as the blocker is getting active, this amplitude is coming down. At present, this is a total twitch depression. But what is the clinical utility of this? Though the twitched height is indirectly correlating with the level of blockade, the margin of safety is very, very narrow. And the useful, not much of useful, because of various reasons. Number one, it needs a control value. This control value should have been done prior to administration of the relaxants. And all the time you need to remember that. So that's the reason why it doesn't have much clinical utility, except for finding the supramaximal value. Earlier, it was suggested that intubation can be done with the disappearance of twitch, but now it is no more acceptable parameter. But what is the most important aspect of using this SAST is for comparing the potency of the relaxants. So it is mostly useful in the research, in the experimental as well as the institutional levels. Clinically, it doesn't have much value. Then we'll move on to the next one. It's called that strain of 4, which is the most commonly used one, which was introduced by Ali et al. In way back in 1970, where a series of twitches with a frequency of 2 hertz with a duration of 0.2 milliseconds with a gap of 500 milliseconds is administered. So what we are going to see here is, this is the elastic preload which I was talking, so that this immobilizes or rather it doesn't allow the unnecessary movement of the thumb. Only when the thumb is stimulated, this senses the acceleration. This shows better variability than the one which doesn't come out with this elastic preload. So what we are expecting here is, in case of non-depolarizing muscle blockade, as the blockade gets bigger, deeper and deeper, we see the responses or twitch height is going to be reduced, and gradually it becomes each one will start disappearing. Whereas in case of depolarizing block, what happens is, when all these 4 stimulus is delivered, there will be a twitch depression, but there is no fade. All the time it's going to show the 4 twitches. So you cannot have the ratio of TOFR in case of depolarizing blockade. So what is this TOF ratio? Where the ratio between 4th and the first twitch. So what we need to remember here is, the appearance of the fade will start happening only when the 75% of the receptors are blocked, and till the time there is no obvious fade. The 4th twitch will start disappearing when the 80% of the receptors are blocked, and the 3rd twitch will start disappearing when 85% is blocked, Second twitch, around 90% receptors are blocked, and the total disappearance of the all 4 twitches will happen only if 95% of the receptors are blocked. So how are we going to use this chain of 4 in our clinical practice? So either by having the count, which is called as TOFC, chain of 4 count, or finding out the ratio, we can come to certain conclusion. When you're talking about this chain of 4 count, it's just mere number. How many twitches we are seeing or we are being picked up by the machine, the equipment. It tells you that what is the level of blockade, whether the blockade is superficial or shallow or it is deep and other things. And what is particular or what is needed for that particular surgery, we can decide about based on this TOFC. Whereas TOFR is, the ratio is used mainly for determining the recovery and residual paralysis. To be more precise, the one of the best or one of the commonly used clinical sign to assess the residual paralysis is our sustained headlift. When this is compared with the TOF ratio, we have found the sustained headlift of 5 seconds is associated with the TOF ratio of only 0.6. But beyond that also, there are a lot of paralysis is present. So then, till 2000, it was considered as 0.7 TOF ratio is enough to say that patient has recovered full. But yes, it does, it shows the recovery of the diaphragm. But what it doesn't show is the, when you are talking about 0.7, it doesn't show about the recovery of the pharyngeal and laryngeal muscles, as well as their response to the hypoxemia. I mean, hypoxemic response, the ventilator response to hypoxemia. So the present guidelines say TOF ratio of only 0.9 only is considered as the complete recovery, because yes, it will have complete control of the ventilator response to hypoxemia as well as the recovery of pharyngeal muscles, where the patient will not have any effects of the residual paralyzation. Okay. But we cannot administer this TOF frequently. The machines will have an inbuilt mechanism so that when it is done seriously, that every 12 seconds, 10 to 12 seconds, will be the TOF stimulus will be delivered. Okay. The third type of stimulus is Titanic. It's we all would have read it in the physiology, where the high frequency of stimulus, where when it is delivered, it's going to cause a sustained contraction of the muscle involved. When we talk about high frequency, there are multiple frequency ranges being used, starting from 30 up to 200 hertz. But what is clinically useful is this 50 hertz, because this correlates well with the maximum voluntary effort. So at this 50 hertz, the neuromuscular junction undergoes the severe stress, and it's a presynaptic event. So whenever the tetany is delivered, that impulse is or the burst is delivered, it stresses the response, I mean, the neuromuscular junction, and excessive amount of hostile current is being released. So what we expect in this is, in an unparalyzed muscle, the response is going to be very sustained for a period of 5 seconds. Whereas when it is used for a paralyzed muscle, that is your non-depolarized with a non-depolarizer, the peak tension will be reduced, as well as there's going to be this contraction is not going to be sustained, it's going to be a fade. But in case of depolarizing blockers, there is no, the contraction will be sustained, but only there will be a reduced peak tension. But the problem with tetany is clinically it doesn't give you much information. That's why, and also sometimes it produces maximal pain. So this is not, most of the time it is not used in our perioperative period. But what is used is the concept of post-tetanic potentiation. What exactly this post-tetanic potentiation is, as I have already told you earlier, when this tetanic stimulus is delivered, there will be a lot of mobilization of the acetylcholine from the presynaptic vesicles into the junction. So at this time, after a brief pause, if you deliver one single twitch, the twitch height will be much higher than the control value. That's because here you have a lot of available acetylcholine stores, so which will drift or shift the balance between your competitive blockage and the acetylcholine. So that is the reason why we call this as a post-tetanic potentiation. So this concept is used to detect the deeper blockade. So what we do here is, After a stimulus of Titanic, that's 50 hertz for 5 seconds, there is a pause for 3 seconds. Then there will be 20 consecutive or continuous stimuli is delivered. Then based on this, we assess the response. So as the stimulus goes on, we start getting the fade because the acetylcholine is getting exhausted. So it depends on the number of responses. Whatever the number of response we are going to have will determine what is the depth, what is the depth of the blockade. If there is no PTC, that is, if even not a single one, then it means that PTC is 0 and it shows deepest block or intense block. If it shows 20, the blockade is very, very shallow. So what are the clinical? Okay, this is how it is going to be there. Let's see. So that's a Titanic. That's a Titanic contraction. So after a brief pause of 3 seconds, the stimulus will be delivered 20 consecutive single touch at 1 hertz. It depends upon the level of blockade, the number of twitches will be. So in this case, if the monitor is going to 20 twitches, that is the evoked potential developed at thumb is going to be 20, that means the block is very, very, very shallow. Where in this situation, so you can see the twitches are being, that stimulus is being delivered, but there is no obvious response. Okay, in this situation, we see, so only seven twitches are coming, which means that the block is not very dense. So what is the clinical utility? So in situations where we want to maintain the block very deeply, for an example, either microsurgeries or ophthalmic surgeries or neurosurgeries where we want to maintain the block very deep, yes, we should have a PTC count of 0. At the same time, if you want to predict the twitch appearance in TOF, that also can be used, because earlier studies have clearly shown if the corresponding to particular twitch, what is the time limit for the appearance of the first TOF response. So based on this, we can time our the dose, and of course to predict the recovery. But we cannot repeat it more often than 6 minutes. The instruments or the equipment will have the inbuilt mechanism. You cannot, unless you switch it off and switch it on, you cannot give this PTC count within the 6 minutes. The last pattern of stimulation is double burst stimulation, which was introduced, the latest one, this 1989. What exactly it does is, here we are, the earlier one we were giving only 1 Titanic burst. Here we are giving 2 Titanic bursts with a gap of with a pause between 750 milliseconds. So the concept here is, when the second Titanic burst is given, the contraction that is going to be produced is much less than the first one if the neuromuscular junction is blocked with the competitive blockers. That's the, we observe the, check the ratio between the second response to the first response. Sometimes the stimulus will have both, stimulus will have 3 impulses or 3-2, but clinically used one is 3 and 3. So if it is in case of non-depolarizers, the second twitch will show the fade. So that's a double burst stimulation. And if it's a quantitative monitor, it shows the fade. The advantage for this double burst stimulation, it is very easy to compare 2 twitches rather than the 4 twitches that's going to happen with the train of 4. And in the train of 4, visibly, or we cannot make out any fade higher than 0.4. But in case of double burst, up to Tof ratio of 0.6, we'll be able to see, or we'll be able to indicate. So it's considered as better indicator in case of subjective assessment. For an example, you don't have a qualitative monitor, only quantitative monitor. For the purpose of recovery, don't rely on TOF, but go for the DBS. That's the concept. So in a nutshell, actually, this is the basic one. When the TOF ratio is around 100, the muscle relaxant is not active. Then gradually, once the muscle relaxant start acting, the ratio starts coming down. So once it reaches 0, that means your 4th count disappears. Then we start counting the TOF count. It becomes 4, 3, 2, 1, 0. Once it is done, once the 0 count, if you want to measure or monitor the neuromuscular function at this time, you have to go for PTC. And there is no point in measuring the PTC here because it doesn't give any information. Okay. So to summarize, we need to have the quantitative monitor where we are going to monitor the neuromuscular function, not evaluate the neuromuscular function. That's number one. The best place where the function of the neuromuscular to be monitored is the ulnar nerve adductor polycystic complex. Okay, for some reason you don't have an access for that. What should I do? The next option is posterior tibial and flexor hallucis brevis, where you are going to check the or see the flexor as per plantar flexion of the big toe. And if you have a quantitative monitor, that the sensor has to be fixed here. And this is for the facial nerve. The present ASA guidelines doesn't recommend the facial nerve stimulation. So when are we going to start the neuromuscular monitoring? Actually, the number one, start earlier, because if certain machines come with the need for calibration. So this calibration has to be done before administering of the neuromuscular blockade. So immediately after the interaction, you calibrate the system with the single twitch and find out what is the supramaximal stimulus, and then you are ready for subsequent monitor and you administer your relaxant at that time. Okay, so initially I said this is useful for guiding the intubation. So are getting the better conditions under intubation. What type of pattern or what pattern is good for assessing the intubation time? Whether the TOF ratio of 0.9 is enough or it should have a total suppression. We know that when remember that we are measuring in the adductor polycys, but your pharyngeal, laryngeal as well as the diaphragm are much more resistant. So even if TOFC is 0, it doesn't clearly mention or clearly mean that your intubation condition will be perfect. So if after TOFC of 0, you wait for 30 to 60 seconds, then perform intubation. At that time, the muscles will be totally paralyzed and you will have a better intubating condition. So can I differentiate a block based, whether it is a depolarizing block or a non-depolarizing block? Of course, there are various modalities available. It's available in the text. You can go through that. So how do I classify the degree of the block? So when we say complete block, the PTC count has to be 0, which is used for ophthalmic or neurosurgeries, as I've already told you earlier. But most of the surgeries, when you say deep block, PTC should be more than 1, but there should not be any TOFC count. That is, TOF is 0. This is called deep block. But moderate block is the one which we use for most of the surgeries. Unless we want extensive relaxation, the TOF count of either 2 to 3 is enough. And shallow block that means the patient starts showing signs of recovery. That means all 4 twitches have come and the ratio is less than 0.4. And minimal block is 0.4 to 0.9. And acceptable recovery is only more than 0.9. So what level of ideal TOF is ideal for most surgeries, which I have already told you, around 2 to 3 TOF count is enough. So in case if I want to maintain the patient very deep, PTC count has to be 0. There should not be any response for the PTC. Then if the PTC is 0, when should I give the next relaxant dose? Of course, these graphs have been derived based on various studies, and you can go through this a little later. Will I be able to predict the time of the recovery? Yes. So in this is basically done based on the racuronium. So if you have the profound block, it lasts for about 5, maximum of 15 minutes. Then the full recovery takes nearly about 20 minutes. So based on these studies, you can find out where exactly your patient lies. For an example, a patient is showing a total TOF count of 3. Then that means the block is moderate, and the very short time the patient is going to show the signs of recovery. So this is the most important question. In case if the PTC is 0, the surgery gets over, then can I reverse the patient now? Yes, if you have Sugammadex, that too with a very high dose. So since it's not available with us in India, with neostigmine, you should never reverse the patient with a PTC is of 0. So at what level we are going to reverse if the neostigmine? So with the neostigmine, they say only after, the present guidelines say only after TOF ratio of 0.4. That to be remembered. Okay, so that means all 4 twitches have to be present. So here this 0.13, and this is also not the time to reverse the patient. And if you have a qualitative monitoring, it is going to be very, very useful. So that means for the recovery and extubation, you have to extubate the patient only after the recovery ratio of 0.9, that is TOF ratio of 0.9. Okay, I don't have the quantitative monitor. So I have only the qualitative monitor. What mechanism or what pattern of stimulation should I use for assessing the recovery? The DBS seems to show better subjective evaluation rather than the TOF. So always go for this DBS. So take home message to summarize: start the neuromuscular function at the earliest, and it is appropriate you to use the facial nerve corrugator in case if you want to study for intubation. This is there, but now recent recommendation goes against this, and avoid total inhibition of the train of 4 during surgery, because most of the surgeries they need about only 2 twitches are enough, and visual tactile response to detect a fade in TOFs accurate only with TOF ratio of less than 0.4. So if you are going to rely more on the visual response, it doesn't tell you whether the TOF ratio is whether 0.4 or 0.9. So you have to be very careful. For sufficient return of pharyngeal muscle function, TOFR more than 0.9 is reason. That is the reason, unless the TOFR is more than 0.9, don't extubate. So at the same time, if you are relying too much on clinical sign, it clearly says clinical signs of recovery does not rule out residual paralysis. You need to be very, very careful. So finally, quantitative monitoring is all time or any time better than visual or tactile assessment. So for further reading, this is a recently released neuromuscular monitoring guidelines by the ASA. So all the pages, you can go through that and get the best out of your neuromuscular monitors. Thank you.
Yeah, thanks a lot.
At this time, I would like to thank you very much for your opportunity to share my thoughts and knowledge. Sir, any questions? I'm ready to take.
Yeah, it was long required and not being given the importance it is due, basically in terms of neuromuscular monitoring. In our, at least our institutional setup also. So despite so many recommendations, we still tend to avoid the use of neuromuscular blocking monitor, even when it is available. So that's one of the things which I observed. And even despite the recommendations and the guidelines, even in Western countries.
There is one survey which was done recently in the Western, which shows only about 10 to 12% of the anesthetists are routinely using this neuromuscular monitoring. So we are also not very much behind, at least.
But I think it is a deterioration in the sense that something like this 10 years ago, they showed 30% of the people used it. Now, if you say
it becomes 12%,
15% means it has come down further.
Because we do rely on the clinical signs too much, in spite of repeated evidences.
Yeah. So basically, my concern normally is about the post-operative period. So as you say, majority of us are comfortable with the clinical assessment of neuromuscular recovery, and we are there in the intraoperative period through and through. The risk is in the post-operative period with residual neuromuscular blockade, where probably there is a greater requirement of assessing the neuromuscular function. Definitely, probably a little bit more than what we do in the intraoperative period. Apart from the surgical indications, as you said, sometimes we need a very deep block for laparoscopic procedures and eye surgeries, and wherever we want an exactly very deep anesthesia.
There are two areas in which to explain that, the two areas where this neuromuscular monitoring can be extended. One is, as you said, is our post anesthesia care unit, and the second one is the ICU. So these are the two areas where we can still extend our neuromuscular monitoring use, because recently that I think it is in the BJE or NSC, I'm not very sure. The article came, they have studied that in PSU, especially after they studied the immediately before extubation, and one group, that's a control group, and the post-operative, whenever the patient developed a complication, the airway related, immediately they have done the TOF. So they have found out that nearly out of this 12,000 odd patients, 0.8% patients had developed the secondary complication, secondary to residual paralysis. So they are insisting it on, in case if you are not using it routinely intraoperatively, at least at extubation, and immediately after that need to be used. But for that, we should have the neuromuscular monitor. But most of the places, we do not have the quantitative neuromuscular monitor.
And of course, what would influence, apart from the assessment, the simultaneous use of inhalation agents. So all
Yes,
of
sir.
us are now exposed to more potent
Your screen is so
I mean, in case the potential body has undergone a long procedure with the non-dependent relaxants, they are reversed. So the patients come back to the operation theater due to some surgical indications. So imagine laparotomy, which has taken about 2 to 3 hours, and the surgery is over at 12 in the noon, and patient is brought back at around 1:30 or 2 p.m. So what would be the considerations and the requirement of neuromuscular monitoring in terms of the choice of the relaxant for intubation? What is the role of succinylcholine? What would be the role of using non-dependent relaxant in the background of patient having received neostigmine while being extubated for the first surgery?
within short time we are going to
Get back the patient to OT.
So there are only two options. So actually, if the indication is going to be a rapid, you need to have a rapid induction and intubation. Either if it is, if you have rocuronium, definitely that will be a better option. But even if you are going to use succinylcholine for that instance, we can still monitor and we can find out whether the patient is having the phase 2 block or the phase 1 block. So this neuromuscular monitoring is going to help to differentiate the phase 1 or phase 2 block. In case if the patient secondary to this, I think if you are going to, because since the patient has already received a neostigmine, maybe I will not use succinylcholine. If it is available with the rocuronium is available, then I'll go for the rocuronium, or it's we have to go for the non-depolarizing and assess the responses.
Yeah, so that's why it's theoretically there are too many considerations. That's the reason I just raised that question. So it's always possible that we avoid both the relaxants, both the types of relaxants, and we may decide in terms of inhalation induction and probably trying to intubate the patient with sufficient depth of anesthesia. So that's one option. And of course, as you say, we may have some reservations with using succinylcholine. We may have some reservations with using NDPs also. So that's one possibly one important situation where definitely we could be checking the blockade using neuromuscular the monitor.
At least we can avoid the subsequent doses. We can allow the patient, we can allow the block to recover and then wait for that.
Then wait for it also. So that's something which can be done simultaneously. The questions very well explained. Of course, there have been a lot of complimentary messages, very informative, nice presentation, well done, very well explained. What would be the scope of the neuromuscular function monitoring in, say, pediatric patients?
So pediatric patients, we don't have much difference between the adult, and as far as the response is concerned, we don't have much difference between the pediatric and adult population. Even though most of the studies are being done with the adult, what is mentioned is pediatric consideration. There is not much difference between the pediatric and adult population. Only thing concern is, especially if you are coming across a CVA patient where one hand is paralyzed. Don't use that hand for the monitoring. You go for the normal hand because of the upregulation of the monitor. Upregulation of the receptors. You may underestimate the block if you are using the neuromuscular monitoring in that particular hand, especially in the CVA patient.
Yeah. So there will be definitely this technical issues in terms of the physics and the electricity, the amplitude and the frequency and everything. So
certain areas where this gap of knowledge gap is available is where especially for all the muscular dystrophies and where that area is not completely assessed. What will happen when if there is a normal when compared to the normal Tof ratio, what should be the for all those muscular dystrophies, we still believe this 0.9. Unless they show 0.9, we are not going to extubate. But in this situation, is it really wanted, or you want a complete recovery? That areas are still not completely analyzed research area. That is where the knowledge gap exists.
So we have a question from Dr. Parimala. How to titrate reversal drug dosage based on train of 4 ratio?
So to start with, normally, since Sugammadex is not available, that takes out thing. But theoretically, what they say is the high dose Sugammadex, that is about 16 milligram per kg, is useful if the PTC count is 0. But if the PTC count is more than 1, or TOF ratio with TOF ratio is less than 2, where we can use the 4 milligram per kg dose. If the TOF ratio or the TOF count is more than 2 and TOF ratio up to 0.4, we can use 2 milligram per kg. That's for the Sugammadex. Anywhere, anytime you can do. But as far as we are concerned, we are left with the neostigmine. So the neostigmine dose is actually 0.03, as we all know. 0.03 to 0.05 milligram. Actually, the minimal dose, what the present recommendation say about 0.03 milligram per kg. That should be, if you have a quantitative monitor, only after appearance of the fourth twitch, when the TOF ratio is 0.04. That is the best time to use neostigmine as a reversal agent. But we know that the neostigmine is the maximum action, the peak action is going to have 10 minutes after that. If the 10th minute, if the recovery does not show 0.9, TOF ratio of 0.9, then you have to wait at that time. So there is no point in, yes, I have given the dose, the recovery ratio, TOF ratio is 0.6, I'll extubate. No, that should not be practiced. That's a recent guideline say, unless you give the, it takes about 10 minutes. So unless the TOF ratio shows 0.9, do not extubate. The reason behind this, yes, the diaphragm is also, diaphragm would have got recovered. The patients will be able to breathe nicely, but the problem is with the pharyngeal, laryngeal muscles. Yes, their tidal volume, vital capacity, everything will be all right. As long as the tube is there, they will breathe. But the moment the tube is removed, there is a high possibility that there is a chance for the airway obstruction or a flare. So if you want a perfect airway after extubation, we have to wait for the TOF ratio of 0.9. So administer neostigmine only when the TOF ratio of 0.4.
But if you are not monitoring, is it still possible for us to correlate certain clinical signs of recovery with different levels of TOF, even at this point of time?
There is one big the table which I have not included. I think starting from the diplopia and other clinical.
Just I wanted.
See, one, in case if you don't have this monitor, sustained headlift for 20 seconds seems to correlate well with the 0.9 of TOF ratio. That is the best response, not the 5 second. If you see that graph, the sustained headlift for 20 seconds, nearly all the patients show 0.9 of TOF ratio, but that we should take that as the clinical parameter which can be as close as possible to quantitative monitoring, not the 5 seconds headlift.
20 seconds. Okay, no, everything, as you say, no, everything was 5 seconds. The head lift and leg lift, hand grip, and everything. Supposedly most reliable for 5 seconds, but now you say it is 5 seconds is not enough. We must be even targeting 20 seconds.
Yeah, 5 seconds correlates well with the TOF ratio of 0.4 to 0.5.
Okay. Again, Parimala has asked if TOF ratio is 0.9 at the end of surgery, sometimes whether reversal drug is needed.
So usually if you are at the end, if the surgery is 0.9, the patient will be definitely breathing. So getting a, before the surgery is over, getting a TOF ratio of 0.9 is not advisable, first of all. Okay, for some reason you have a TOF ratio of 0.9 at the time. The present guidelines say if you are going to use an intermediate acting muscle relaxant, antagonism is mandatory. Maybe you can reduce the dose from 0.05 to 0.03 milligram.
Yeah, safe to do, definitely.
Yes.
There is that question, you can see from Dr. Kiran Sen. So not totally related to, but we may try to correlate. Does the universal time of waiting for about 2 to 3 minutes after an intubating dose of a non-dependent relaxant is still required with addition of inhalation agents as well as nitrous oxide.
Only based on the clinical, the question, is it about the only clinical based or if you have a neuromuscular monitoring? If you have a neuromuscular monitoring, this 3 minutes is not needed. You just wait for the complete suppression of all 4 twitches, then wait for 30 seconds and you can go ahead with intubation. We need not wait for this mandatory 3 minutes.
Yeah.
When I checked, usually it comes about 2 minutes and 1.45 minutes, 2 minutes that the entire twitch depression happens. Then after that, the 30 seconds we need to wait because we want at the time adductor pollicis would have paralyzed, but not the laryngeal and diaphragm muscles.
Okay.
Sir, one small question, sir.
Wait for that 30 seconds.
Yeah. Yes,
Sir,
sir.
good evening, sir. Good evening, sir.
Please, sir.
Really very nice topic for especially for postgraduate and practicing anesthesiologists, sir, because many centers who don't follow this neuromuscular monitoring. So usually helpful for postgraduates especially. And one my small question, sir, because even today we go by clinical assessment, and sometimes we give after the full dose of reversal agent, sometimes the patient may not be recovering. So then are we justified in giving the additional dose of neostigmine, or we have to test for the neuromuscular monitoring and go accordingly?
So as for if the patient does not show any signs of recovery immediately, there is no point in giving the next unless we have used very low dose in the first attempt. For an example, if you used 0.02 or 0.03 milligram, yes, maybe we can try. That's also been suggested. But already, if you have used 0.05 milligram, that's the maximum dose of neostigmine. There is no point in repeating the dose because the maximum effect that is going to happen, that 10 minutes, is already happened. So the receptors are not going to take any additional neostigmines. So we are just loading the patient with neostigmine, but without any additional benefits. You have to wait. You have to wait for the improvement in the spontaneous recovery. Then maybe an additional dose will be helpful, but not a second dose if you are using already the maximum dose of neostigmine.
But because it is a competitive block, no, sir, it all depends on the number of.
Right, because even that's why the word the neostigmine resistant polarization came. Actually, if it will be effective only when the competitive or the neuromuscular blocking agents have come down to a certain level. So if the spontaneous recovery has not happened, that means these blockers are still active. The non-depolarizing blockers are still active. So whatever the dose beyond which this 0.05, if you are giving beyond which, it is not going to displace the your existing non-depolarizing blockers. So you allow the non-depolarizing blockers to get exhausted, wait for that time, then you give the antagonize the block, then it will be the recovery will be there. What about what is your comment, sir, Balabhaskar sir?
Yeah, no, pharmacokinetics doesn't change. No, we have to follow up the pharmacokinetics, which is long proven for each of the drugs, whether it is atracurium or pancuronium or rocuronium. So it has got a fixed pharmacokinetics where the drug would go and sit on the neuromuscular junction for a certain period of time. Again, there is no question of competitive inhibition because it is there. It cannot be displaced. So there is certain duration of time it is sitting there. And only when the pharmacokinetics allow it to be displaced, like gradual metabolism in the liver, then the concentration gradient allows it to be displaced from the neuromuscular junction. So that is the time gradually it can be replaced by the neostigmine. So that, the cholinesterase would act anticholinesterase, allowing for accumulation of acetylcholine. Only then that the antagonism, competitive antagonism would work. So at the initial periods when the drug is still attached to the neuromuscular junction, it is not advisable, therefore, to clinically try to attempt to reverse it by giving more and more the reversal agents.
Even if it shows some response, the response recovery will be transient only.
Yeah.
After very short time, the patient will go for residual or the recolarization will happen in the. So we should not attempt a second thing.
And it has been, I think, catastrophic also. Many of us know with previous experience, any attempts to do like that, there will be an apparent improvement. Patient would put out the tongue, open his eyes and all, and he may feel very happy. But the next 5 or 10 minutes, there have been severe hypoxic episodes and probably mortalities in some reported cases. So definitely we should not be hurrying. with the second dose, allow for the drug to act. If it is not acting, basically it means there is still that much of depth of neuromuscular blockade. In the absence of neuromuscular monitoring, of course.
Yes.
Yeah.
That's the important thing. And in fact, for a previous discussion, Dr. Malarbiji has posted a small correlation in terms of the qualitative peripheral nerve stimulator values of train of 4 and the effect of the dosage of neostigmine and sugammadex as a comparison. Anybody who's interested, it is there in the chat box. So that has been put up as a image. Next, okay, this question is related to what we were discussing. Sir, will there be any adverse effects of neostigmine if we give after Tof ratio of 0.9, like cholinergic crisis?
I'm not able to understand the question. What is that?
You can just read it. Will there be any adverse effects of neostigmine if we give after Tof of 0.9 is reached, like a cholinergic crisis? So I think what they are doing,
because as long as you are within the normal range of thing, this will not happen.
Yeah, it will not happen because it is a recommended dose.
Recommended dose.
Particular effect. It's not going to happen, definitely. And Dr. Girish has asked what kind of response is seen in TOF when we give succinylcholine after pre-periodization dose of vecuronium.
It's a good question. What kind of? So I have not checked it, but if you go by the scientific evidences, since the block that is going to happen is only the depolarizing block. It's only the phase 1 block. It is not the phase 2 block. So that's why actually the only the twitch height will be reduced and there will not be any fade, because it depends upon whether you pre-polarize that is not the block that is going to be produced is only the phase 1 blockade. So the features of phase 1 blockade only will be demonstrated or will be exhibited.
Okay. In fact, I think his phrasing, he's trying to ask, but the phrasing is not correct. So what probably Dr. Girish is implying is like to a measure of, vecuronium to reduce the instance of vesiculations after succinylcholine.
Yeah.
Okay, that he is representing. Then what will happen when you give succinylcholine? I think it will still be a depolarizing block.
Depolarizing block only. So signs of depolarizing block only will be, there will
seen.
not be any fade or so only the twitch depression.
Yeah. So that much of dose of the non-depolarizing is also not administered.
If you show signs of fade, that means we have already gone to a phase 2 block.
Okay. Right. Hello.
Oh, yes, sir. Yeah.
You are there, no? Sorry.
Yeah, I am there.
Sorry. Okay. Suddenly, I thought there is some network issue.
Yeah, there is a pause in the video.
There was a pause in the video. So, I think that we had Dr. Samshad Madam also in the group.
Good evening, madam.
Okay. Right. So it was great to have Raajesh, beautiful presentation.
Thank
the
you,
advantage is it is there in the YouTube. I will share the link.
Okay.
And why I am trying to say it's an advantage is many of one of the reasons we also decided to have this topic was we have the neuromuscular monitor and
what you have the quantitative monitor with you, sir, or we just monitor with your peripheral nerve stimulator?
The old one is also there.
Okay.
The new one is purchased
and cost is
EMT
also not
also
very high. That module costs only about 1.75 or 1.5 lakhs additionally only.
Yeah.
Yeah.
That is there. And the systems with the GE, which we have got along with the entropy, also we are getting that NMT. So that can also be definitely correlated with what is discussed today with respect to axial magnitude. So that's not a problem. So that way, it has been a great benefit for all the students who have
It's a
participated.
privilege for me. It's an honor for me, sir.
Yeah, as Dr. Subramanian was telling, it's also mix even the practitioners, private practitioners to think and again take the opinion from the experts like you. So nice of you. And Dr. Parimala?
Yes, sir.
Yeah, Dr. Josna is there?
No idea, sir. Shall I conclude,
Okay, right.
sir?
Yeah, please. Anything else from the group? I think that there is no posting. So any queries, we will still share with Dr. Raajesh later on.
Sure.
And we can also call him for another presentation if some of us have not understood in a greater detail, definitely.
Okay, sir. Sure, sir.
You can please conclude, Parimala.
Okay, sir. Okay, sir. Thank you. So it's our great pleasure to hear from you, sir.
Thank you.
Okay, I can say that the perioperative neuromuscular monitoring was made easy by you, sir. And this topic is most required one. I think our PGs and whoever participated in this session, they have understood it nicely and enjoyed this weekend feast, academic feast. On behalf of Department of Anesthesia and ISA Ballari branch, I thank you, sir.
Thank you very much.
Thank
Thank you. Thank you very much for this opportunity.
Good night.
Thank you, sir. Thank you.
All the best. Good night.
Thank
Happy
you.
New Year, everybody.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir.